Sure, sir. Okay, sir.
So all the best, sir. Thank you, sir.
Thank you, sir.
Thank you.
Video please.
A very good morning to one and all. On behalf of Session College of Pharmacy, I am Amini Kantala. I am Leandrika Mahayan. Would like to welcome our dignitaries for today's session. Dr. Harsha Chalasani, Faculty, Department of Pharmacy Practice, JSS College of Pharmacy, JSS Academy of Higher Education and Research, Mysore. Dr. Kumar V.S. Nemmani, Director of STTP, and Dr. K.S. Nathraj, Principal of STTP. And also, I would like to welcome Pharma Fraternity of various colleges and each and every participant to the Day 2 of AICTE sponsored 1-week online short-term training program on clinical pharmacy services, optimizing patient health, organized by Department of Pharmacy Practice. On this note, I would like to introduce our Director and Principal to the gathering. Dr. Kumar V.S. Nemmani, Director of Sri Vishnu College of Pharmacy since 2018, holds B.Pharm and M.Pharm degree from Andhra University, Visakhapatnam. Sir had completed PhD from NIPER, Mohali, and subsequently postdoctoral fellowship from McGill University, Montreal, Canada. Sir had over 14 years of industry research expertise on drug discovery and development. Introducing our principal, Dr. K.S. Nathraj, completed his B.Pharm in Gulbarga University and M.Pharm in T.N. Dr. M.G.R. Medical University and subsequently PhD degree in Pharmaceutical Sciences at JNTU Anandpur. Sir has wide research experience and several DST and AICTE research grants to his credit. Sir has worked in various teaching designations and currently he is serving as a professor and principal of our college. Now I request our faculty, Dr. Raghu Bapiraju, to give a welcome note.
So it was my immense pleasure to welcome Dr. Sri Harsha sir to deliver his talk on Day 2 of this AICTE sponsored STTP on clinical pharmacy services optimizing patient health. Really, we are fortunate to have you as one of our resource person for this talk. And definitely, I believe that you are one who have practiced, who have been practicing the services from long back. Really, you are one of the motivation for the youth professionals like us. And really, we are fortunate to have you as resource person for this talk, sir. I take this privilege to welcome all the participants who have, in spite of their busy schedule, spending time in order to gain knowledge or in order to gain wisdom from the resource persons what we have, uh, who have been proven to be successful in the field of clinical pharmacy services. And I also thank AICTE for sponsoring this STTP and with this note, I welcome you all for the day 2 of this STTP. So I hand over the session to the moderators.
Now, I feel privileged to introduce our today's Session-3 speaker. Dr. Sri Harsha Chalasani had graduated in pharmacy and qualified GPAT in 2011 and is a recipient of Frank May's Gold Medal in 2013 and completed doctoral research with Department of Science and Technologies, Innovation and Science Pursuit for Inspired Research Fellowship. Currently, he is a faculty in Department of Pharmacy Practice, JSS College of Pharmacy, Mysore, and preceptor for Geriatrics and General Medicine. Sir is an instructor for pharmacotherapeutics, clinical pharmacokinetics, and pharmacovigilance subjects for PharmD and postgraduate courses. Sri Harsha, currently a member of Special Interest Group, Asian Drug in International Society for Pharmacoepidemiology and International Society for Pharmacoeconomics and Outcomes Research, and has publications in reputed journals and has a mention in the New England Journal of Medicine to his credit. Now I request Dr. Harsha to begin his talk.
Thank you for the kind introduction. Hope I am audible to you all.
Yes, sir. It is perfectly all right.
Thank you, sir. A very warm welcome and hearty good morning to all of the participants here in today's session. It is my privilege to be associated with Dr. Bhakiraju, sir, and all of his team. I wish all the best for and all the success for this one whole week training sessions that you are conducting, sir. So, do you all see my slides?
Yes, sir.
Right. Dignitaries, participants, students, and faculties. Today we are going to talk about the basics of the therapeutic drug monitoring. Therapeutic drug monitoring, to brief you out in one line, it is a step forward towards a precision medicine or individualized drug therapy. The days that they are coming to in the future, maybe down the line 20 to 30 years, we will come to see a new trend of medications where you need not to use the same medication doses that we use for every other disease. There will be a day where we can optimize the therapy for the X amount of pain, Y amount of drug, and we are going to titrate the therapeutic responses and the clinical outcomes in a very near future. And for that, the first step that we are having towards is therapeutic drug monitoring. Of course, pharmacogenomics and all will play even important role towards realizing this precision medicine. We have a lot of limitations in our country settings, with the limited resources in order to promote this therapeutic drug monitoring. Let us see what are the basics that are involved and what best we can do. So today's topic, basics of therapeutic drug monitoring. It's nothing but it measures the concentrations of the medicines in the patient's blood or plasma. The amount of the medication in the given, any given patient, it varies greatly depending upon their genetic makeup and also their physical appearances. It is true that no one single drug cannot fit every other population across the world. We have to titrate our doses according to the requirements of the population. Some may be fastest dilators, some may be slowest dilators. Some may tolerate the adverse drug reactions very well, some may not. All these things, all these differences because of the genetic makeup of the individuals. Now, that is the intrinsic factor. Understanding the extrinsic factor, and it solely depends upon the physicochemical properties of the molecule. Now, titrating or balancing both the ends is what therapeutic drug monitoring is. So it is defined as a measurement made in the laboratory where the parameters with appropriate interpretation will directly influence the prescribing procedures. This indeed a great step in order to reduce unwanted adverse drug reactions. We all know that there is not a single medicine which is a safer in this world. Every medicine comes as a double-edged sword where one may have to pay the price if they are used inappropriately. Only that the situation gets worse when we are using therapeutic indexed medications or high risk alert or high alert medications. Either the cases, it is important for us to evaluate how the patient is doing and measure levels of the drug. Why do we need the therapeutic drug monitoring? Well, we need the therapeutic drug monitoring in order to maximize the efficacy and safety of the medication, and to minimize or to prevent the adverse drug reactions, adverse drug effects of those medications which have the narrow therapeutic index. It is performed on those drugs where the clinical response of the drug cannot be measured directly. Let me tell you, friends, when we are taking an antihypertensive medication, it is very easy for us to see if the drug is actually working or not. But when we are trying to take the medications, you see where you cannot have a tangible endpoint on the clinical response, then that is where the problem begins. One such example is the seizures. In certain conditions like seizures or the mental disorders or cancer, it is very difficult for us to see how the patient is doing. We cannot do everyday follow-up with them. It is economically not viable. In these conditions, it is very helpful for us when we can have a TDM done and to make sure that you see the patient is having the adequate doses in their body. Is my pace okay for you all?
Yes, sir.
Bhadraju sir?
Yes, sir. It is okay, sir.
Right.
Am I audible, sir?
There are certain, okay. Yeah, it is audible. Sir.
Yes, yes.
Digoxin, methotrexate, amiodarone, carbamazepine, amikacin, lithium, theophylline, cyclosporins, tacrolimus, vancomycin, gentamicin, and sodium valproate. Now, before we delve into further into subject, let me just introduce you to the basics of the therapeutic index. Therapeutics index is nothing but the ratio between the toxic dose, that is LD50, and the effective dose, ED50. And serum drug concentration is the concentration of the drug in the serum after it has been absorbed, completing, it is a measure of the both the free and protein bound drug. Therapeutic range, perhaps this is the most interesting concept. A minimum serum drug concentration below which the desired drug effect is usually not seen, and the maximum serum concentration above which the toxic effects are pronounced. And the trick is to balance between or within this particular therapeutic range. Friends, an easy thing to remember, larger the therapeutic range, the safer the drug it is to dose around. Minimum it is, the narrower your chances to play around. So, the plasma concentration of the drug, you have to maintain in a way that it is always within the therapeutic range. A therapeutic response that can be expected, anticipated for the benefit of the patient's clinical well-being. If you dose in such a way that, or if the dose, once it enters into the human body and it undergoes a various subjections, you see, if it is not maintaining or if it is sub below or far below the normal minimum therapeutic concentration, then you call it as a subtherapeutic dose, and it is nothing but we are wasting the patient's time, money, and energy, our energy on this. And if you give the dosing above the maximum or the minimum effective or beyond the minimum toxic doses, you call it as a minimum effective or minimum toxic dose. And there it is very difficult in order to control the toxic effects of the patient. So we are putting the patient into the adverse event scenario where we have to take care of the excessive costs and other maintenance charges in order to bring back the patient that was subjected for this adverse events because of the higher dosing. So ideally, we should maintain the dosing between these two limits: minimum effective concentration, minimum toxic concentration. So the larger the gap between these two ends, you see, the safer the molecule is. The smaller the gap between these two ends, the dangerous a molecule to handle around. So those are the drugs that I told you: digoxin, theophylline, sodium valproate, carbamazepine, amikacin. These are the certain drugs you see whose therapeutic range is very, very narrow. Hence, we have to perform this therapeutic drug monitoring into these drugs. Now, under what circumstances, one would require the TDM? Well, if the drug has a very complex kinetics, if the drug is having the narrow therapeutic margin, clinical quantification of the drug effect is not easy. Drug response relationship varies very widely. Drug-drug interactions can often lead to the adverse drug interactions. Major changes in the weight, fluid status, renal function, and hepatic functions of the patients to assess the suspected overdose or to suspect or in order to evaluate if the patient is compliant with the or is adherent to the medication regimen that has been given with. So let us see them. The first one is if the drug has a complex kinetics. The metabolism and clearance of certain drugs, such as a phenytoin, are dependent on the dose and the serum concentration at any given point of time. Now, these concentrations can change dramatically with a slightest change in the dose or in the rate of metabolism. Hence, serum drug concentration should be evaluated possibly after every single dose in order to give the optimal therapy to the patient. It is quite possible to do that, but however, limited to the economical constraints, we are unable to do in our hospital settings. For the drugs such as lithium, gentamicin, digoxin, and phenytoin, overlap between the concentrations associated with the therapeutic effects, and that those are associated with the toxicity. Such drugs require a great deal of therapeutic drug monitoring. We know that digoxin, when it is used for the arrhythmiasis, and if it is not properly monitored, it itself can induce the arrhythmiasis, and that can complicate the whole situation. For the want of controlling the arrhythmiasis, the prescriber may prescribe even more bigger dose or may administer another dose, and that may ultimately push the patient into the toxic zone, and the patient may have to suffer from the toxic effects or the side effects. When the clinical quantification is not possible. For example, if you're looking at, as I said, that if you're looking at, antihypertensive medications, you can check your blood pressures, or one can check for their blood glucose levels, and they can say that if their medications are working or not. But in certain conditions, it is very difficult to measure because the goal of therapy is usually the absence of phenomena. For example, the same phenytoin, if you take, if the person is taking the phenytoin for the want of controlling the seizures, the absence of the seizures is the the goal of the therapy. And how long are you going to observe it? You never know that when it might kick inside. And what are you going to do? You have to continue to take the medicines. What if this medicine is slowly poisoning your liver or the kidneys of the patient? Then what are we going to do about it? Hence, we require to do a therapeutic drug monitoring to see that if that particular serum drug concentration of that particular drug is well within the range of the given adjustments. Sometimes it is not also easy to distinguish between the signs and symptoms of the disease and the adverse drug reactions of the drug therapy that we have selected. For example, nausea, anorexia, or arrhythmias can be seen both in the congestive cardiac failure as well as the management of the congestive cardiac failure that is with the digoxin. Hence, the serum drug concentration of the digoxin may be helpful in understanding the cause of it. Do you know that adverse drug reaction is to see that the serum drug concentration when the reaction or the adverse drug reaction is in its peak? Whenever you have a doubt that there are 3 or 4 drugs given to the patient, and all these drugs are known to cause a certain reaction, and you take the concentration, you just evaluate the concentration of the drug in the serum, then you will get to know that the one with the highest usual thumb rule is the drug with the highest serum concentration is the drug that is responsible for this particular adverse drug reaction. Thereby, you can down titrate the dose for the benefit of the patients. Dose-response relationship varies very, very greatly. The metabolism of the drugs such as procainamide and paracetamol entirely depends upon the acetylation status of the patients. Hence, the same dose in two different patients may lead to quite two different serum drug concentrations. There are two ways to explain this situation. Depending upon inherent acetylation status of the patients. Some are fast acetylators, some are slow acetylators, some are moderately acetylators. We, the Indians, are the moderate acetylators. We have the normal acetylation rate, whereas Japanese people often record them as the slow acetylators. Hence, the doses of the paracetamol varies within these three populations. And whenever you are giving for the same medications which have to undergo the metabolism using the same enzymes that are meant for drug A and drug B, there would be a change in the pattern of the elimination or the metabolism of the drug thus score. So one has to plan their dosing in such a way that you see that enzyme, the liver, has adequate resources to metabolize the molecule over a period of time without causing any adverse drug reactions. What happens is, because of the preferences or because of the lack of enzymes, one drug may induce enzymes in such a way that the other drug can get metabolized, or then in certain situations, the drug may make sure that it is not at all allowing the liver to induce any more enzymes, and it is because it is inhibiting, then it can lead to the dose accumulation or the medication accumulation in the body, and thus it leads to the accumulation toxicity in the body. So these are the both situations one has to be very, very careful about when they are dosing, especially when they target for the same or similar kind of an enzyme for their metabolisms. Drug-drug interactions. Mostly we might have heard that there are these drug-drug interactions, but how many of them are we reporting them? Do you know that there was a paper that says that most of the adverse drug reactions, if you do a proper time-temporal relationship evaluation, you may see that these adverse drug reactions are nothing but the adverse drug interactions. Most of the drug-drug interactions are not clinically perceptible or tangible. Hence, we cannot quantify them, or we don't know why this particular reaction is happening. Only when we can do the quantification, there is a scale called as a drug interaction probability scale, which will allow us to understand the drug-drug interactions and try to quantify which has led to what sort of a reaction. And thus we can, identify the culprit. Also, we can use this therapeutic drug monitoring to see that which drug is being expelled or pushed into the free-bound form, in the serum, then we can take care. That is a molecule that is responsible for the direct adverse event. This is how we are going to plan on that. So drug-drug interactions, when the quinidine is added to the regimen of the patient who is stabilized on the digoxin, the digoxin concentrations may increase substantially over the next few days, because there is a decrease in the digoxin clearance, which is directly affected by the quinidine's presence in the body. They both fight for the same receptors for the elimination, and hence this is a problem. So what happens? Well, when you are managing the patient, with the comorbid conditions who is having quinidine therapy, then the patient may end up in developing the toxic effects or the side effects associated with the digoxin. Hence, it is very important for us to understand how to identify the pinpoint problem or identify the problematic drug and how to address it at the earliest. So we can use therapeutic drug monitoring to find what is happening in the patient's body. Another problem is if there are certain, the normal drugs, yes, we can take a chance of a day or two and we can see how the patient is responding to the therapy, and we can alter the medications accordingly. But when you are dealing with the narrow therapeutic index drugs, friends, we might not have sorry for that. We might not have much of a time, to wait and see if the body can adjust to it. Also, not to forget to mention about the, the physical appearances of the body. Whenever I said that, it is regarding the adipose tissue to the muscle ratios. Adipose to the muscle ratios will also greatly play a role in the distribution of the drug, and thus further compromises the overall explosion or the expulsion of the drug from the body. When all these complex situations comes into it, it is nearly impossible for the clinical pharmacist or the physician or any healthcare professional to quantify how much of should be the next dose. So the best thing to do in these situations is go ahead with the therapeutic drug monitoring. Where what we will do there? Well, we will draw the blood sample and we will understand, we will analyze it and we will understand what is interpreted values are for. If the concentration levels are high or the concentration levels are low than what it is anticipated, you see, then we will take a clinical judgmental call accordingly, and we will make sure that the patient gets the best therapeutic outcome with the given medication scenario. Major changes in the weight, fluid status, renal functions, hepatic functions of these patients. Of course, we all know that the weight and the fluid status can change the volume of distribution of the drugs, while renal and hepatic functions, you see, whenever they change, the pattern of the is also compromised. Factor called intermediate syndrome. Heard about the intermediate? The greatest example that I can quote regarding the impact of the weight or the adipose tissue in the body and how soon it may appear in the patients. Usually in a person with a normal BMI, you see the intensity and the extent of this intermediate syndrome usually appear from 7th day till 9th day post ingestion of the organophosphates. But when you look at a person who is on a higher side of the BMI, the chances of the extension of this particular intermediate syndrome can be seen up to 14 days, and it would be very, very bit of a difficult to manage such patients. Similarly, whenever there is one more drug that has entered into the systemic circulation and also fights for the similar metabolism or also demands similar resources for its metabolism, then it will further complicate the situation, and thus it leads to further overall accumulation in the body and potentiates the toxicity the patient is suffering from. So what we have to supposed to do? Well, understand the therapeutic drug concentrations, understand the serum concentrations of that particular toxin or the poison or the drug, and see that what give the best of it. This is not just in the poison patients, but also in the pregnant woman. In the pregnant woman, the content of the levels of the water or the fluid will be more. So you see the dosing becomes again hazardous to an extent as they progress in their trimesters. Hence, it is important for us, before we dose a patient or a person who is carrying a child, it is very, very important for us to understand, as one of the principles suggests, that you have to start slow and go slow. You should start low and go slow whenever you are doing the dosing, so that the fetus will have minimal effect on the impact on the fetal will be very, very minimal, so you can avoid untoward outcomes such as teratogenicity in the mothers. Then in the obese patient tissue, thus you see the plasma drug concentration for these drugs are very, very low, and thus results in the higher volume of distribution. And this may warrant for a next alteration in the dose. So that is what we have taken whenever we are coming across a patient about, in the medical literature, whenever you see they calculate these dosings, if I'm not wrong, as I read that patient, who's having a normal BMI, that is what they assume whenever they put across their calculations. Now, continuing to that, the drugs that have the low solubility in the fat remain in the plasma and produce higher plasma concentrations, and thus they result in the smaller volumes of distribution. But in advanced patients, see the plasma concentration of the drug may be low, and once they may result in higher volume. In both the situations, see the doses have to be adjusted accordingly. Otherwise, the whole purpose of the medication therapy would be, it will be kind of you will not see all the whole equation quickly gets us. Then what will happen? The patient, who is not experiencing any therapeutic benefits, they will have a flood of therapeutic.
Sorry, sir. Yes, sir. We can. Yes, sir. We can hear you now.
Hello.
Yes, sir. We can hear you now.
Okay. So this is what we were talking. So as I was saying, you see the patient will experience a flood of therapeutic benefits, and then it can sometimes translate into the adverse events, and it will be very difficult to manage such a situation. So in order to assess the suspected overdose, that is another goal that we have to take care using TDM procedures. So you see promoted by the signs and the symptoms of the overdose.
Sir,
what happens in the Indian scenario is, most of the times we will say that it is an alleged poisoning case, alleged, poisoning or suicidal attempt with so-and-so ingestion of so-and-so component. We don't know. Yes?
Yes, sir. Yes, sir. I mean, meanwhile, in the middle, there is a slight.
Am I audible, sir?
Yes, sir. You're audible, sir. There are some network issues in the middle. That's why. Yes, sir. You can continue now, sir. We can hear you clearly. Thank you.
Thank you. So most of the times you see, we treat any poisoning cases depending upon the TOX syndrome. Well, do you know that I have read certain case reports, or in certain cases where the doctors have confused between the carbamates and the organophosphoruses poisoning. They both may have the similar TOX syndromes, but their antidotes are entirely different. And if you choose atropine to manage a carbamate, then the outcome might not be very, very well appreciated. So you see, how best can we avoid it? Well, why don't you perform a therapeutic drug monitoring and see what is going to happen there? And if you can manage, if you can correlate the TOX syndrome with the serum concentrations of whatever the toxin that is present, I think that should be fine. Here, the only difference of the therapeutic drug monitoring is we use a qualitative test instead of the quantification of it. And of course, most of the poisons don't need to be quantified, because you see, the quantification, the concentrations of the serum drug, they rarely correlate with the toxin syndromes. It is essential for us to understand if there is a poison or not. If there is a poison, what is that poison is? If this much we can know, then we can take care of the rest of the situations. We can suggest for the symptomatic management, or we can ask for the supportive therapy, or if you know that there is a specific antidote, then we can go ahead with that particular specific antidote. So we can use to identify the culprit in this kind of situations. At times, you see, we also come across in our own practice, we have come across patients who comes with a cocktail of the toxins ingestion, or too many medications. The patients may sometimes, they just take it, for the wide variety of reasons. So when we are managing such kind of a situation, what should we aim at first? I mean, what we should reverse first? Should we have to look at the drug, in the order of the drug they have, medicines they have overtaken, or should we have to address it symptomatically? What if the symptoms are secondary to the ingestion of multiple drugs? So whenever such a dilemma occurs, you see, therapeutic drug monitoring actually gives us the best answers. Analyze for the serum and see that whichever the drug is having the highest serum drug concentration or plasma drug concentration, start to reverse it as much as possible. You can use, a diuresis whenever possible. We can use the dialysis whenever it is possible, or hemopheresis whenever it is possible to pull out the molecule. And thus, you see, you remove one after another drug, automatically the TOX syndrome also subsides. And that is how we save the patients. Bhabiraj sir, is it audible now? Are there any?
No, sir. Yes, sir. It is audible now.
Thank you.
But there are some slight network issues from your side, sir, in the middle of the session. But it's okay. It is being resolved.
It's manageable, right?
Yes, sir.
I think the classes have started. That's why I'll try to. I hope it will be better now.
Okay, sir. Thank you, sir.
Now, coming to the last point, that is, suspected patient compliance, or maybe in an Indian scenario, we might not see the insurance companies playing a huge role as in the Western, Western population, where the insurance determines everything, how the therapy has to go around, for how long it has to go around, and if they're taking the medicine. So what's the reason maybe? We usually come across a situation the patient cannot tolerate, and the patient cannot tolerate the adverse reactions or the side effects. They try to avoid taking the medications on the daily basis. And also patients, whenever they are economically affordable, they might buy the medication and they take them, and while technically they would just skip on the medicines. Either the situations, you see, the outcomes, the therapeutic goals are
Sorry, sir. Sir, your mic was in mute, sir.
Can you hear me now?
Yes, sir. We can hear you now.
I think I have changed this thing now. Hopefully it should be better now, sir.
Yes, sir. We can hear it clearly now. Thank you, sir.
Yeah. So you see, when we are talking about the compliances, especially when you are talking about the patients who are suffering from the cancer, or who are receiving the chemotherapy, you see, because of the adverse drug reactions, or such a way that everyone every day they have to live for live with a feel of nausea, vomiting, and immense pain, they may or may not actually go adhere with the plan of a regimen. Now, what happens out of that? Well, as long as there are two ways to look at it. If you're talking about the patient who is suffering, if you're talking about the patient who is paying out of the pocket, we cannot say that, well, it is patient's money, we can't do it. No, it's not like that. It is the loss of the loss of resources is the loss of resources for anyone else. Even it involves in your time, energy, effort that you keep it in. Some patients, they may forget, they may be forgettable, forgetful, like because of the old age or elderliness or staying alone. They may take too many medicines, or they may not take medications at all. Either the situations, you see, which can compromise the plan of medications, you have to see that the patient, we can ask the patient, like, are you taking the medicines? The patient would obviously say, yes, I'm taking the medicines. And what is the guarantee that the patient is actually taking the medications, isn't it? So when such a situation occurs, it is always better to do something called as therapeutic drug monitoring, to see that if at all the patient is taking the medications as prescribed, then the patient should be having adequate serum drug concentration levels. Well, this also gives us an understanding. I will share you a small anecdote that I have come across. So there was a cancer hospital here where I'm working, dedicated cancer hospital, which is supported by the government agency. And the patients who are below poverty line are supported by the insurance policies and all. The government will pay the basic amenities and the medicines also. And there was this old person who is around 59 years old and suffering from the colorectal cancer, was put on the chemotherapy. However, as per the government policy, they can give the basic, medication to manage the chemotherapy-induced nausea and vomiting. they cannot afford to the higher amount or higher or the more potent drug. Now, what happened after 3 or 4 cycles of the chemotherapy, the patient has come back to complain that he's unable to tolerate this nausea and vomiting feeling, and he cannot go to the work because of that, and it is compromising his quality of life, and therefore he doesn't want to continue with the chemotherapy, and he just want to let the life take its own course. Now, the doctor has posed us a question: is it a good situation or a bad situation? For understanding the patient's pain, yes, I know it is a good situation if the patient decides, because the cancer also has progressed to the advanced state, and the patient wants to live or have a peaceful time, whatever it is left with. Yeah, personally, you can honor that request. But when you are looking in the other side of it, you see the government has paid the money. The government has paid the money, and the government has taken care of it. The valuable resources, time, energy, everything has been put into the patient, and now the patient decides that they doesn't want to continue with the therapy. So if not invested in this patient, you could have very well put those resources into some other patient who is waiting in the line. So there are both the sides we have to understand, and we have to balance this situation. So therapeutic drug monitoring once again will help us in understanding how best we can titrate the doses in such a way that you see the patient's adverse drug events or the adverse drug reactions are kept to the minimal, and therefore they'll continue to be more adherent to the medication on the long run. Now, ultimately, excuse me. Now, what are the criteria for the drugs to be selected for the TDM? The concentration of the free drug at the site must be consistently proportional to the concentration of the drug in the serum. The degree of the serum protein and tissue must relatively they should remain constant. In other words, the extent of the free form to the bound form should stay at least not exactly constant, but at least in an acceptable measures, so that you can interpret the concentration fluctuations in the body. Now, what is the basic information that is required for planning a therapeutic drug monitoring? Importantly, you should start with the demographics. It is necessary for you to have the age, sex, race, height, weight, and to estimate the body surface area, creatinine clearance, half-life, and the dosing suggestions that the patient is receiving. Why this is important? Yes, it is important because you cannot expect a paracetamol to act the way it is acting in the Indians, in the African Americans as well. As the population changes, their race changes, the genetic makeup changes, and it will have its own pronounced effect depending upon the genetic makeup. And the history and the physical examination are also very important for us, because certain physical conditions which we think that it is not necessary to evaluate may be influencing the disposition of the drug, such as the early stages of the kidney failure, they are virtually non-detectable, or the early stages of the diabetes, they also are non-detectable, and they both will be suffering internally, and thus it will be also compromising the drug disposition from the body. And the presence of the edema or jaundice or any other dehydration conditions, once again, it will alter the volume of the distribution and the metabolism of the drug, and thus the excretion of the drugs. And the excretion of the drug is compromised, then it leads to the accumulation toxicity, and the patient has to suffer from the adverse drug reaction. So what we usually do, we will stop that particular medication immediately. Thereby what we are doing, well, we are depriving the patient of their therapy. And what does it lead to? Well, the patient will have to continue to suffer with the diseased condition, whatever they have. And in all this process would involve in the waste of money, resources. Now, it is also important for us to understand the drug and the dosing history. It is essential for the proper interpretation of the serum drug concentrations. Just because the serum drug concentrations are above the minimum toxic concentrations, we cannot say that the patient is poisoned or overdosed, or on the opposite side underdosed or subtherapeutic doses. We have to understand, did the patient take it properly? When was the last time the patient has taken the medication? All this information is important for us to interpret whether the process that we have done, is it essentially correct or not, and thus accordingly we have to move forward. And the laboratory parameters that you also have to consider, you see, which directly, both the kidney as well as the liver function tests are essential in order to understand the functionality of the patient's, physiological parameters, because these are the two vital organs that are responsible for the metabolism of the drug as well as the elimination. If either of them, they are not performing properly, there would be a direct fluctuation in the serum drug concentrations of many of the medications. Hence, before we jump into any conclusion whether the patient is having the toxicity or not, or the patient is suffering from a toxic untoward effects or not, we have to understand if the elimination, that is the kidneys, are they functioning normally? If they are functioning normally, then why there is a elevation in the serum drug concentration? Or is the liver functioning normally? If there is a functionality of the liver is normal, then why would be there is an issue with the metabolism? Or is there any drug that is interacting with another drug such a way that they are fighting for the same binding site or the elimination route? Then that is how you will identify the problems associated. Often, of course, the drug cannot defend itself whenever we put it into the center of attraction. Hence, we have to have a judicious mechanism to balance all the loose ends. Now, it is also important for us, what if you have done any of the recent or the earlier reports of the serum drug concentrations? It is important because you see, with one report, you cannot be very sure what is happening because the timing of the sampling might not be correct. The procedure that you have done might not be correct. The blood that is collected into the, there are different colored vacuotiners, if you know that. There is a red color, purple color, blue color, and all these things serve different purposes. And if instead of taking the blood into the red vacuotinor, if the person who is drawing the blood in the purple or some other vacuotinor, it compromises the whole situation and you may end up in getting a wrong values. So the whole purpose of tedium is lost. And therefore, it is important to see that how the patient is doing with the previous sampling that has been done. Now, after all these things are done, this is the most important thing what the pharmacist can do in the therapeutic drug monitoring. That is nothing but the organization of the TDM, or they call it as what are the steps that are involved in the TDM. First, the pharmacist and the physician will try to develop recommendations of the doses, and they will try to understand what should be the target concentrations. Here at JSS, what we do is, you see, the chemotherapeutic doctors, the cancer doctors, they speak to us. They will tell that this is a patient, this is of the cancer, and this is the body surface area and the body mass index. Now we want to start with 5-fluorouracil or or any other cancer drug they will come across, and they will tell that we want to adjust the dose, and this is the target that we are planning. How best can we go it? Can you do the therapy regimen for us and get back to us? This is a kind of a conversation we usually go through. And thus, for that step to realize, we need the information such as age, sex, height, clinical status, and the physical appearances of the patient, all those things. And once that is done, we will calculate the LD and the loading dose and the maintenance dose, and we will put the recommendations across to the physician. In our hospital, we have a system where the professor, it's a teaching hospital. So a professor is supported by the associates, assistants, residents, and the interns. So when we at least communicate this issue to the associates, assistants, and the head, then you see they will take a call whether it is a viable plan for the patient or not. And if they require any other alterations, they do this accordingly. And once that is done, after say 7 half-lives, once we calculate at least 7 half-lives, or in certain conditions where the half-life is too large, you see maybe 3 or 4 half-lives, then we will ask to organize the sample collection and select the method of analysis. Then the physician usually consults the clinical pharmacist to determine which sample is required, serum or plasma, and what time that particular sample has to be collected. If there is a question as whether to choose adequate dose has been achieved, or you want to check if whatever the drug that you are giving has it reached its optimal level, then you should ask them to collect the blood sampling during the trough levels of the drug. I'm sure you all know that the area under curve graph, and the area under curve graph, it's nothing but an inverted bell shape. And the inversion, you see, when the drug touches the minimum effective concentration, and that particular concentration is what you call it as a trough level of the. And the peak levels are usually obtained 1 to 2 hours after the oral intake, approximately 1 hour after the intramuscular administration, and 30 minutes after the IV administration. Peak level is monitored or measured to see that if the adverse drug events or the poison or the toxicity is because of those medications. So whenever a poison patient comes to you, you see if it is within the 1 to 2 hours of the oral ingestion of the medication, medical components, then you can check for this one, peak concentrations. And therapeutic concentrations that are measured at the trough levels are usually meant for the, the therapy optimization. Remember these 2 points. For the patients who are having the suspected symptoms of the drug toxicity, the best time to draw is when the symptoms are at their peak. So for one such example, when the phenytoin is being administered to the patient and the patient develops ataxia, at that ataxia time, you have to draw the samples and you have to see, to what level the phenytoin concentrations are there. And you can quickly reverse accordingly. Organophosphorus also follows the same rule. So you see, you need not to go ahead and do the atropinization haphazardly. We can do with a calculated dosing, and thus, we can reduce the adverse events associated with the atropine, such as psychosis. That is one of the hardest thing to control the patient with. However, we should also understand the risks involved in the collecting the blood samples, because often the blood samples are collected by using venipunctures. This can lead to the hematoma, fainting, or loss of excessive blood or internal blood tissue damages. So these things have to be taken care of. Identify where the samples has to be sent. It's not possible that one hospital can house all sorts of sample evaluations. You have to identify the place where that particular sample has to be done. We usually do it in our drug therapy drug testing laboratories. When we don't have the particular column for the HPLC, or when we don't have a particular system to evaluate it, well, we will send it to the nearest ones. Previously, when in a couple of 4 or 5 years ago, I remember we used to send the samples to the Amrita Institutes of Medical Sciences Poison Control Center. So we have to give the proper instructions to the nurse regarding the time of the sampling and the sampling tubes that are supposed to be used. That involves the volume, color of the sampling tubes, the volume of the blood to be drawn. Minimum is at least 1 ml of the blood should be drawn. And even then you will only get only 0.5 ml of the serum or less than that. Hence, it is advised, if it is an elderly population, make sure that they are well hydrated, because elderly patients are the ones who usually have the pain in giving the blood. Once the sample reaches to the lab, the qualified technician should only perform the analysis, and we should clearly tell them what we are looking for. Well, the problem is, you see, the trust issues in the forensic laboratories, they will not tell that what they are looking for. They'll just ask, find a black cat in a dark room. When it comes to the medical thing, we cannot do like that. We have to tell that, see, I'm suspecting so-and-so overdosing of a so-and-so medication. I just want you to confirm if my hypothesis was right or wrong. If you don't know what the patient is actually suffering from, then subject the sampling testing for the qualitative analysis first, and then put it to the quantification. And once again, the poisoning substances, you see, most of the times they don't require the quantification, because they poorly correlate with the toxindromes to their serum concentrations. Hence, when you are doing the dosing for the drugs, then you have to take care of it. And choosing the best analytical method is the most important thing. You see, if at all, the temperatures of the particular gas, there are various methods that we have to analyze this particular therapeutic drug monitoring, and each molecule responds differently. So you have to be very, very cautious about which method you are selecting, such a way that the specificity and the sensitivity are well acknowledged in that particular model. And we cannot choose, for example, we cannot choose, where you have to use the flame or fire in order to assess that particular, assay of that particular molecule. If at all the molecule is a heat labile, then the whole process is gone to the waste. And we have to also continuously standardize the assay processes. It is the best to have, something called as nomograms. These nomograms will give us, immediate understanding what next should be done. Have you heard about the nomograms? And one such is, Rumax. Put that together. And we should also understand if there is any drastic physical change in the patient's condition. And when we put all these things together, you see, that is when the things will start to make sense. And thus, accordingly, we can alter the dose of the patient. But the limitations, of course, cost, expertise, availability, transportation of the sample, and then last and most importantly, the possibility of altering the doses if it is a solid dosage form. This is how a TDM request form looks like. So here you can see suspected toxicity, possible drug interaction, therapeutic confirmation, lack of therapeutic response. Number of drugs to be assayed, what is the dose, frequency, dosage form, route of administration. Friends, that is about the basics of the therapeutic drug monitoring. Remember, we do not pay a very serious attention towards our drug-drug interactions, but most of the drug-drug interactions can manifest as an adverse drug interaction, and that can further manifest as an adverse event. And what we will do, we will try to attribute that particular reaction to the drug which is having the highest incidence. But in reality, that might not be the situation. The interactions at the molecular or at the receptor level is responsible for the adverse event. And how best we can alter this? By doing the therapeutic drug monitoring. Maybe it is expensive using the HPLC and other methods, but it is also quite possible to see that with the normal therapeutic drug monitoring concentrations. Thank you.
Thank you, sir, for your enlightening presentation. I'm confident that we have learned something from it. And now the session is open for questions.
Are you saying something to me?
No, so for the audience, I'm requesting any questions if they have.
We have a question in the chat box. What are the TDM drug services which you provide in your hospital?
As I said that we have a drug testing laboratory which is recently accredited by the NABL, and now we are expanding our scope of services to the chemotherapeutic agents and the poisons also. We have a colleague in our pharmacy practice department who is currently working on in his doctoral research in quantifying the poisons in the patient's blood biological samples. So now we are also expanding our services to the suicidal and other such scenarios. Usually they use the column C18, which is the most commonly usable thing for the most of the valuations of the drugs.
Thank you, sir. So there's other question from the participants, sir. Is it necessary to have an ethical code for doing or publishing a therapeutic drug monitoring project, which is a part of treatment protocol?
Oh, thank you for that. But Bhadraju, can you please repeat the question for me? The child's voice is little.
Yes, sir. Yes, sir. So the question is there any ethical committee approval required for doing this TDM project or for doing this type of studies?
For two simple reasons. One, you are doing it on the want of project. And whenever you're doing it as a want of a project, you see who has to pay for that. Second, it is a biological sample. So someone has to authorize it. What if the patient has to give more than 2 samples or more than 1 sample where it may involve the paining the patient, right? So understanding these two situations, it is essential that you obtain ethics committee clearance. Do you know that there is a new act called as NDCT, New Drugs and Clinical Trials Act 2019. And it clearly says in chapter 4 and chapter 5, which speaks about the biomedical research, that if you are going to even take the name or any other details of the patient for your project or any purpose, research purpose, you have to obtain their consent. And this has to go through the ethics committee. If you're handling any patient information or divulging the patient information to anywhere, then you have to, yes, go through the ethics committee.
Thank you, sir. There's another question, sir. Why TDM is not so effectively taking place in many hospitals? And is there any possibility to overcome the situations?
Yes. Thank you for that question. That is a very valid one, because I myself have experienced during my project in the master's. My master's project, if I remember, I was doing it in 2012. It was in the quantification of the toxin levels in the patient blood as a clinical pharmacy student, as a pharmacy practice student. That time, you see, the problem is to, back in 2012 only, if I have to evaluate the concentration levels of the digoxin or organophosphorus, it is costing somewhere around 1800 to 2400 rupees per sample. Now, for my results to be, statistically significant, forget about the clinical significance, I would require at least 300 patients. So 300 into 2000 rupees minimum. So don't you think so? It is a very expensive process. Okay, even if the institution provides you with the supplementation, the carbon 18, column itself costs around 25,000 rupees, and it can only run 100 samples at any given point of time. So who has to bear the cost? And even if I equip all that system, and if I don't get the adequate samples to be, analyzed, that particular column will be wasted. So ultimately, why most of the institutions are not able to have it is because the sustainability of the system. If we can find a way where we can do the sustainability, then we can take a lot of care of these issues. So that is where, we are still having, and also you can understand, most of the patients, you see, I mean, imagine you go to the wards and you tell to the patient that we are suspecting or we want to measure the concentrations of your drug in the blood. And for that, you need to pay. What do you think the patient would say? Right? So there are pragmatic issues, that is preventing, but otherwise we can. But do you know that I could able to do the qualitative tests in my organic chemistry lab? The basic first year organic chemistry. You remember the Fisher test, all the basic tests. I could able to do that if the patient is having organophosphorus or not. And I can, I could call the doctor immediately and tell that yes, there is a, there are the traces of so and so poison, and they would immediately start the therapy accordingly. Because we have seen where the patients are confused, the healthcare professionals are confused between carbamates and organophosphoruses and initiated one therapy to another therapy. So before it is too late, we can do something, and slowly we can we can generate the evidence, and that could move, make the people to move towards utilization.
Thank you, sir, for patiently answering all the questions.
Thank you.
Next session will be started within a couple of minutes.
So thank you, Dr. Harsha sir, for your spending your time with us. And really, your session has a thought-provoking session for most of us. Definitely at our level West will try to establish a TDM center so that we can help the students as well as the society in improving their knowledge for the students, at the same time health for the citizens.
The only problem is, sir, we do not, when we are counseling the patients, we do not counsel about the long-term effects of the particular drug. For the simple reason, when we counsel a patient that, with these drugs, these are the anticipated side effects, you don't know if the patient would really come back to you. You don't know if the patient would take the medications. So with such an ambiguity, yeah, but I wish you all the best. And the students as well.
So thank you, sir. Thank you so much, sir.
May I leave the session?
Yes, sir. So thank you once again, sir.
Thank you.